and get started. Just to let everyone know, we're recording the session today. When it comes to the Q&A, I'll either turn it off, or if I can't, just be confident that that won't be included in the recording that we'll share online. It'll just be the presentation part, just so everyone's aware. For those that don't know me, my name is Jay Sloan, and my pronouns are they, them. And I'm really pleased to be here on behalf of the Proud Science Alliance as one of its co-chairs. If those of you on the call aren't familiar with the PSA, we're a collective of life sciences and healthcare organizations working together to create more inclusive, equitable, and thriving environments for LGBTQ plus people across our sector. And this session is part of the Safer to Be Me Summit, and it really demonstrates our ongoing commitment to share knowledge, spark dialogue, and drive meaningful change. In fact, this is our second session in the series, and today we're turning our attention to an issue that lies at the heart of our mission and has far-reaching implications for LGBTQ plus people globally. Now, we know that despite progress in many parts of the world, stark inequalities remain in healthcare access, quality, and outcomes. And today's sessions explore some of the systematic barriers behind those disparities. And those include discriminatory laws, undertrained providers, data invisibility, and cultural stigma. And all of these things intersect across different contexts. So we'll also look at what drives change, things like inclusive education, evidence-based practice, advocacy, and policy reform. And I'd invite those of you on the call today, as you listen, to really think about how each of us can play a role in creating more equitable systems of care. And we will have time later in the session to hear your reflections and also have space to ask questions. So with that, it's my great pleasure to introduce our speaker, Professor Catherine Meads, Professor of Health at Anglia Ruskin University. And Catherine is a senior researcher whose work over 3 decades has focused on improving health outcomes for LGBTQ plus communities. From evidence reviews that shape practice to clinician education and advocacy, her work turns data into better care. We are thrilled to have her perspective with us today. So with that, Catherine, I'm going to hand over to you.
Thank you very much. That was a lovely introduction, and I'll, if I can have a copy of that, I'll use it elsewhere as well. Yes, okay. So what I'm planning to do is talk to you for about 25 minutes or so, and then have the rest of the session as question and answer. If you would like to put, while I'm speaking, if you'd like to put the questions in the chat, then after I finish, then we can go through the chat questions and people who'd like to raise their hand up and ask questions face to face as well. So both of those ways of asking questions is absolutely fine. So I will put up a slide set that I've done and share with you. If you just bear with me just a second. There we go. Okay, so hopefully you can see that.
Yes. Oh, good.
Yeah, okay, right, let's kick off. So this is me, Catherine Meads. Right, I'm a professor of health at Anglia Ruskin University. I am a trained doctor with a PhD, and I used to do a lot of work for the National Institute for Health and Care Excellence, which is a body in the UK that assesses whether new interventions are value for money for the National Health Service. And I was on the evidence team assessing that for quite a long time. And that's how I learnt to do a lot of the systematic reviewing and health technology assessment that I currently use now on LGBT health. Now, I actually started on LGBT health research before I started in academia. And but recently, I've been able to give evidence to the Parliament, an inquiry on LGBT health research and about reproductive health, but that was one particular area I've specialised in. Also, under the Theresa May government, there was an LGBT advisory panel, and I was one of the individual members on that. And that was really interesting because it was a way of seeing how research evidence could actually be abused in a practical way to generate better government better policies, better legal advice and stuff like that. But unfortunately, after the Theresa May government fell, the LGBT advisory panel was no more, and that experiment is no longer there. So, as I said, I've been doing LGBT health research for quite a few years. So these are some of the projects I've been involved with. Some haven't quite yet been published, but others have been around for quite a while. So, and I've been part of the community for donkey's years. This is me on a pride float somewhere in Birmingham. So I'm sure you all know about different ways of defining our community. So with sexual orientation, the reason why I put this up isn't because people don't know about this, but because the publications that I'm putting together in systematic reviews, some of them define their populations by identity, some by behaviour, some by relationships or marriages. And they are not the same. So Geary did a very interesting project recently, 2018, seeing how, say you have within the outer boundary, this is all sexual minorities of one way or another. It's by behaviour, by identity and attraction. So there are people who are attracted but don't identify as gay. There are people who have same-sex sex but don't identify as gay and don't think that they have same-sex attraction, but they're having same-sex sex. Now, if you're doing research in this area, you can either just go by identity or just by attraction or just by behaviour. Notice here that doesn't have the marriage or relationships in either. Or you can include all of this messy bubble. And then once you add in gender identity on top, it gets even more complicated. You know, who are we actually counting here? How do we know who we are? And what's the best way of tackling research in this area, given that it's not as straightforward as some areas? So again, some definition. I'm sure you'll know a lot more about this than me. And also, but right, when I was talking to some masters in public health, international health, global health students just last year, I was talking to them about LGBT health inequalities. And quite a lot of them were from all around the world, in places like Uganda, Nigeria, all over everywhere. And there's one guy who put his hand up and said, but homosexuality is a mental illness, isn't it? And I saw this sea of faces, and I realised that half of them thought that sexual orientation, me being a lesbian, was a mental illness in itself. So I was going to have to do a lot of work to explain to them that it was a normal variation in society. Now, I hadn't been faced with that attitude for a long while, and it really made me think about why are people coming from that direction. So then I looked at, are we that unusual? And actually, no. Sexual orientation, behaviour, obviously you can't find identity in animals, but behaviour, very common in all sorts of different animal groups. Also, variations in gender markers can be found in many species. And then you can Google multigender mushrooms, which is even more interesting because there's multigender mushrooms who've got two loci. One has a choice of male and female, and the other loci has 4 choices. And then between the two of those, there's an awful lot of variation. So it's not just X and Y in the whole, of our world. So current global state of LGBT health inequality. So it speaks to 2 of the Sustainable Development Goals specifically, which is Goal 3, good health and well-being, and 10, reduced inequalities. But where LGBTQ plus people's rights vary hugely by country, and by different parts of the country and is changing all the time. It makes it very difficult to know quite what's going on. And essentially, the health inequalities are occurring due to consequences of a complex interaction of environmental, social, cultural, and political factors. So, how to tease out all these different factors? The results, you can see the results, but you can't distinguish very easily which particular aspects are causing the results. We have lots and lots of evidence around poorer physical health outcomes, higher rates of mental health problems, significant barriers in accessing healthcare. There's stigma, discrimination, lack of understanding from healthcare providers, and it's leading to a fear of seeking care, avoidance of treatment, and experiences of violence and harassment in some places. Now, if you're working in health inequalities, most of the time you see evidence around deficit models. These identify the problems and needs of populations, but it tends to make people feel that the population is sick, and it shows the population in a negative light, and it doesn't necessarily show ways of getting out of the problems or alleviating the problems. An asset-based approach looks at how to focus on resources that promote self-esteem and coping. And within our community, there are a lot of resources, and we need to remember that over and over again, how much resource we do have in our communities. So the official publication record shows a lot of health inequalities knowledge, not just in LGBTQ plus people, but in all sorts of other minority groups. But there is much, much less on how to alleviate the problems. And it's a realization that's sort of developing now that actually it's not, you can't just assume that if you've shown that there's a problem there, that the leadership and people sorting out services know what to do to alleviate those problems. Often it ends up on a too difficult pile, and they just go, oh, right, okay, that's a problem, and I don't know how to deal with it, and nothing happens. So we've been showing that there are LGBT health inequalities for years. And, you know, the evidence that we're getting is even more strong now. We're starting to see things like higher rates of deaths by suicide. But there's no movement yet on what to do about it. So in the UK, there is somebody called Professor, what's he called? Marmot, Professor Sir Michael Marmot, who is one of the heads in health inequalities approaches, but he will not go anywhere near LGBT health inequalities, in spite of being asked numerous times, which means that the Marmot cities that are set up in the UK to tackle health inequalities are not tackling LGBT health inequalities. Obviously, that's not the best way of tackling them. So here are some typical deficit models of this is sexual orientation, mental health problems, suicides, etc., etc. It's a bit depressing, really, and it sort of gets involved with politics. So I put this paper up. This is from 1998. So this is the Cameron papers. They extrapolated some rather dodgy evidence, and the conclusion was that homosexual activity may be associated with a lifespan shortened by 20 to 30 years. Now, anybody reading that would be going, but that's ridiculous. I mean, I should have died by now. Not only I think he was talking about homosexual men, but he doesn't say anything like that, but equates homosexual with drug abusers, and I mean, there's a whole website debunking these sorts of reports. But the other reason I'm putting this up is some research is dressed up as research, but actually is propaganda and based on political negative viewpoints. And this was one of the spurs for me to actually think about how can you produce much, much better research, which is much more accurate and not driven by political negativity. Right, in gender minority, we have had Katie Saunders, who produced a very good paper around the rates of mental health and learning disabilities and other issues in the trans community of the UK. We don't have equivalent mortality data from the UK, but there is some from the Netherlands. But here is an asset model. Okay, so Trish Hafford-Letchfield and team develops an action research project in 6 residential care homes for older people. And there is a lot of problems for some older people in care homes. There have been deaths. There's been battering and really bad behaviour by some care workers towards gay people. And this was a way of tackling this. And the volunteers from the local community trained care home staff, and it worked. It was a really good initiative and demonstrated positive and tangible long-term improvements for both residents and staff. So has the care home sector taken it up en masse? No, they haven't. And you think, why is that? Why hasn't it happened? It works. And it would be better for staff and residents. But there you go. There's one of these barriers that's stopping the evidence that is available from being applied much more universally. So Hatzenbuehler is a guy from the States at Harvard who has done a lot of work on the links between the legislative and environmental policies of different states, and its impact on the health of the LGBT population. So he found this is a systematic review, found 98 studies that linked objective measures of structural stigma to mental and behavioural and sexual health and physical health, and the consistent evidence that structural stigma increases risk of poor health. And stigma, negative perception of prejudice or unfair set of beliefs, social norms that preference and prioritise heterosexuality and cisgenderism. So all of this stuff that, this negative stuff that gets in the way of people actually treating people well, is causing us harm. So institutional homophobia has been defined as the collective failure of an organisation to provide an appropriate service to people. So one example happened during COVID in the UK. Despite our best efforts, this study was not funded by a UKRI COVID initiative. At the time of writing, nothing out of £90 million was awarded to projects studying experiences with LGBTQ plus people. Surely that's a classic example of institutional homophobia and transphobia. I mean, it's outrageous that out of £90 million, there was nothing around the LGBT community. I mean, it's ridiculous. And at the same time, the Minister for Equalities, the Right Honourable Kemi Badenoch, said this is in the Hansard, government vigorously scrutinises research from a wide range of sources on the impact of COVID-19 minority groups, routinely monitor research, and have not found that LGBT groups specifically have been disproportionately affected. There was no evidence, absolutely no evidence. There was no research. And there was no evidence provided by the government, the Office for National Statistics, or any other routinely collected data around COVID in the LGBT population. In spite of being asked numerous times to do that, they never did it. So we still have no idea how COVID really affected the LGBT community. And then just in a routine prostate cancer clinic, okay, this is an example from a qualitative research paper. So a trans woman needed a prostate screen and insisted on being, the staff insisted on calling her Mr. Smith. I mean, what would you do in this situation if you'd never go back, would you? I mean, this is ridiculous. But why are the staff not being trained how to talk to patients properly? Right. So when people are talking about structural stigma, it's not just being part of a minority that's killing us. It's the lack of general social acceptability of that minority. And a classic example of this is in the Vietnam War. There was a helicopter pilot who tried to prevent a massacre in a village, and he airlifted some of the villagers out, and as a result of that, he became an outcast and was shunned for years, and he died from alcoholism, no, and died from cancer, probably brought on by the being shunned and suffering from PTSD and all the other negative things that happened because of what happened during the Vietnam War. I mean, eventually he was given a medal for the bravery that he showed at the time, but it was a bit too late. So we know that with legislation, the structural stigma is correlated with adverse health outcomes. And there, in the US, for example, Hatzenbuehler and team have done quite a lot of work around denial of services to same-sex couples. And this is an example where the laws are causing mental distress. And if you move from a place which has better legislation compared to worse and vice versa, it affects your mental distress. In the UK, there is the Equalities Act that's still in force. It came in 2010. Now, it is likely that this actually has had an impact on people's mental health. I don't think the government really understands the link between legislation and the population that it's legislating about. So there have been some very negative legislation and some very positive legislation. And nobody really has measured the impact of this on the mental and physical health of the LGBT population. Now, which brings an idea, a notion that if you have a government that has directly invoked a negative piece of legislation, can you sue them for its impact on your mental health? Be very interesting. Okay, so strategies for building inclusive evidence-based care systems. So addressing these inequalities requires legislation, improved healthcare policies. In the NHS, for example, there's a sexual orientation data monitoring standard that's been agreed and has been around for several years, but it's voluntary, not mandated, unlike the ethnicity one, which means that hardly any of the data is being collected, which means that it's that data field that's being pulled through into the cancer registries. And so they claim to be monitoring sexual orientation and cancer, but there's no usable data because there's nothing in that data field. There is very little push to make sure that all health and care staff understand why a person's sexual orientation, gender identity is important, and there's very little training for some health professionals. They get no training in this area. So if you talk to the General Medical Council, for example, their requirements for junior doctors does not list specific minority groups. So it has much more higher order things around doctors need to know about the populations that they will be working with. So if you talk to the staff in a particular medical school, they'll say, well, I can do some of that by looking at ethnicity and health. I don't have to do sexual orientation or gender identity, which means that the students don't get anything. And then when they are actually working in hospitals, they're being faced with issues that they've never had a chance to think about and talk about. So there is a need to teach health and care staff, and there is a need to mass educate the general population, but is that going to happen with the negativity that's coming out of some political areas? no, where a country imposes the death penalty for homosexuality, and their staff grew up there and come to somewhere like the UK, they are going to bring the attitudes that they grew up with them. And they don't necessarily have cultural competency training when they get to this country. They may have a little bit, but not sufficient to banish the prejudice that they grew up with. But they would be seen as not adopting UK professional standards and values. So there's a situation that's not benefiting anybody. So really, all people need to be safe in their country. They should have access to good health services without discrimination, and to be able to work without fear. And these are all affecting our health and well-being. So in general, public health is political. And we saw some of that during COVID, but public health has always been political. And these health inequalities are real. They cause multiple disadvantage. They start early in life. They cause early morbidity and lower healthy life expectancy. And lack of action means that very little is being done to alleviate the problems. And we need much more about the interventions that will help LGBT people. So thank you for listening. At the end of the presentation is a list of references if anybody wants them. So that's quite enough for me rambling on.
I was hardly rambling from my perspective. It was provocative in the best possible way. It was informative, and yeah, probably other words that I can't form at the moment, but it was like but it also created this real fullness of the picture of what's going on, and also from my perspective, at least, a kind of a peek behind the curtain a little bit, those things that you don't normally get access to in terms of information. But certainly there's a few standouts, but rather than me play back, what really stood out for me, I'm so curious to hear from those of you on the call today, and would really invite you to share, of course, questions, so things that have come up for you that you want to know more about, but also reflections, so maybe something was triggered for you. Maybe you have an example that you'd like to share, whatever the case may be. But yeah, let's just open it up. And who would like to go first? And probably the best way to